the deadliest hospital wing in Appalachia, St. Malo. And let me know in the comments where you're listening from. I'd love to see how far this story has reached. Before 1962, St. Malo's East Wing had a patient recovery rate that matched any regional hospital in Virginia. By 1971, internal transfer requests from staff had tripled, and the mortality rate in that single wing exceeded the state average by 340%. Something changed, and the records show exactly what. This was not a collapse that arrived without warning. It was constructed, decision by decision, across nearly a decade. The data was there, the memos were there, and still, the wing kept running. What happened inside St. Malo's is not a story about one bad actor or one bad year. It is a story about how institutions protect themselves and who pays the price when they do. 47 people. That is the number researchers arrived at after cross-referencing discharge records, death certificates, and state inspection logs spanning a single decade. 47 excess deaths tied not to the hospital as a whole, but specifically to the East Wing, its layout, its staffing patterns, its particular sequence of administrative choices. These were not anonymous figures buried in aggregate data. Many had names, families, documented complaints filed on their behalf. The failures that ended their lives were observed, recorded, and sent up the chain. State-level reviewers read the numbers. They initialed the reports, and then those reports were filed, not acted upon. This is what separates St. Malo's from a tragedy. A tragedy implies the absence of knowledge. What the record shows here is the presence of knowledge, and the deliberate choice to absorb it without response. Somewhere in that chain of reviewers and administrators and appointed officials, someone had the authority to close the East Wing. Someone could have read those mortality figures and said, "Enough." The question that drives everything forward is not whether they saw it. It is what they chose to do instead. 5 layers of evidence. That is what this account moves through. Not 5 opinions, 5 documented categories of fact, each one closing a specific open question, each one adding another weight to the same side of the scale. First, the physical deterioration timeline. Then, the staffing data. Third, the suppressed transfer records. Fourth, the state inspection reports. And fifth, an internal audit that existed for years before anyone outside the institution was permitted to read it. It was not released publicly until 2019. Each layer answers something. Together, they answer everything except one thing. That last question is not about what happened. It is about who was responsible for letting it continue. To understand how the wing failed, you first have to understand what it looked like when it worked. St. Malo Regional Hospital opened its East Wing in 1958. The funding came from the Federal Hill-Burton Act, a post-war program that pushed medical infrastructure into underserved rural areas by converting grant money into buildings, beds, and basic equipment. The East Wing was one of hundreds of facilities built under that framework. It was not exceptional. That is precisely the point. The catchment area covered 6 counties. No competing facility existed within 90 miles. For the population it served, St. Malo was not a choice. It was the only option. And for several years, that option functioned. Through 1962, the Virginia Department of Health placed the East Wing in the 48th percentile statewide on patient outcome measures. That number is worth holding on to. Not the top half, not a model institution, but stable, adequately staffed, and performing at a level consistent with comparable rural facilities of the period. Middle of the distribution. Unremarkable. Functional. That baseline matters because failure requires a before. A facility that was never viable could be dismissed as a planning error, a resource misallocation, a structural problem without a decision at its center. But a facility that was functioning in 1962 and had become something else entirely by the late 1970s is a different category of problem. The deterioration had to come from somewhere. It had to begin at a specific point, driven by specific choices. So the question that the data raises is precise. Not whether St. Maro could have worked. It did work. The question is when the decisions that ended that started being made, and by whom, and whether anyone at any point in that chain acknowledged what they were building toward. The physical deterioration timeline begins to answer that, but it does not begin where most accounts assume it does. The first cut came in 1963, a single line in a board meeting. Nothing dramatic about it. No debate recorded, no dissent noted, no attached study weighing what the decision would cost over time. The board of directors approved a capital reallocation, and with that approval, the East Wing lost 61% of its infrastructure maintenance funding. The money moved west toward a new surgical theater, toward expansion, toward the future the hospital wanted to be seen building. A budget line change is invisible to patients. That is the nature of it. Nobody in the East Wing noticed in 1963. There was nothing yet to notice. The pipes were still holding. The electrical conduits were still adequate. The ventilation was still moving air in the right directions. Deferred maintenance does not announce itself. It accumulates quietly in the way that debt accumulates, not painful until it is suddenly unbearable. What makes the 1963 decision significant is not what happened immediately. Nothing happened immediately. What matters is the mechanism it set in motion. Infrastructure does not respond to budget cuts in months. It responds in years, sometimes in decades. The interval between the decision and its visible consequences is precisely what allows institutions to deny that a decision was ever made at all. By 1966, maintenance logs for the East Wing show a pattern of repeated repairs to the same systems, the same pipe joints, the same junction boxes, the same ventilation shafts. Not full replacements, patches, the kind of interventions that extend function just long enough to defer the real cost again. This is not incompetence. This is a rational response to constrained funding. The engineers working the East Wing were solving the problem they had been given the tools to solve. The problem they had not been given tools for was larger and growing. No impact assessment was filed in 1963. That absence is important. It means nobody was required to model what 61% of lost maintenance funding would produce at 5 years, at 10, at 20. The board did not have to look at the number and sign a document saying they understood the trajectory. They approved a line item. The line item had no future attached to it, and yet the future was already there, fixed by physics, by the rate at which materials age without intervention, by the compounding logic of deferred repair. The East Wing did not begin deteriorating because no one cared. It began deteriorating because a specific decision, made by specific people in a specific room, removed the resources that would have prevented it. The question that follows, the uncomfortable one, is whether anyone calculated that in advance and filed it somewhere it would never be read. Every patch is a decision not to fix. That distinction matters more than it sounds. When the maintenance team submitted the first HVAC work order in 1963, they were responding to a symptom, a belt, a calibration issue, something small enough to address without escalation. The work order was completed, marked closed, and filed. But the underlying system, aged, undersized for the East Wing's occupancy load, never designed for the ventilation demands of a clinical environment, remained exactly as it was. The patch held the symptom. It did not touch the condition. That first order was followed by a second, then a third. The maintenance logs recovered in 2019 tell the story in the flattest possible language. 14 separate HVAC work orders between 1963 and 1967, each carrying the same closing notation. Temporary repair. Full replacement deferred. 14 times, the decision was made to buy time rather than solve the problem. 14 times, the building absorbed the consequence and continued to degrade. By 1966, the accumulated cost of that deferral became measurable. Air exchange rates in the East Wing had fallen below the minimum threshold set by the CDC for occupied medical facilities. This is not a marginal variance. Below standard air exchange in a hospital ward means that airborne particulate, pathogens, aerosols, the biological byproduct of shared illness, lingers longer than it should. It recirculates. The ventilation system designed to protect patients had, through a sequence of patches and deferrals, become an exposure pathway. At the same time, the building's drainage infrastructure was failing in a different register. Standing water had begun accumulating in the subfloor beneath the East Wing. A 1967 internal facilities report documented it clearly. The language was measured, institutional. A moderate infection vector concern, not an alarm, a notation. The report was signed. It was dated. It was placed in a physical file. No corrective order was issued. That gap between documentation and action is where the building crossed a threshold. A hazard that is named but not addressed does not stay at the level at which it was named. It compounds. The standing water interacted with the structural substrate. Moisture migrated upward into wall cavities and ceiling assemblies already weakened by years of deferred maintenance. And then the ceiling incidents began. The records show at least 3 partial ceiling collapse events in the East Wing between 1966 and 1967. In each case, a section of saturated plaster or tile assembly gave way. In each case, the affected area was patched, sealed, and returned to service. The root cause, moisture infiltration from failed drainage, moving through deteriorated structural layers, was not corrected. This is the compounding logic that maintenance engineers call failure stacking. Each layer of deferred repair does not simply add to the problem, it changes the nature of what the next problem will be. A failed HVAC system alters humidity. Altered humidity accelerates drainage corrosion. Drainage failure introduces moisture into structural materials. Structural failure drops debris. Each outcome was a predictable consequence of the one before it. The question worth holding is this: at what point does the building stop being a container for medical care and start being a variable in clinical outcomes? By 1967, the East Wing had 14 temporary repairs, substandard air quality, standing water in its subfloor, and at least 3 structural failure events. All documented, all patched, none resolved. The file existed. The signatures were on it. The building kept track of everything. It was the institution that looked away. There is a class of document that institutions rarely discuss openly: the transfer request. Filed quietly, routed through personnel, rarely aggregated. But when you pull them together, when you lay them side by side across a 4-year window, they become something else entirely. They become a record of what the staff knew before the administration was willing to say it out loud. Between 1965 and 1969, 23 of the East Wing's 31 registered nurses submitted formal transfer requests. That is not a statistic that arrives without meaning. That is nearly 3/4 of the licensed nursing staff on a single ward, in a single 4-year period, asking in writing to leave. The language in those files is precise. Personnel records show recurring phrases: unsafe patient load ratios, equipment non-functional, and in 3 separate cases, a sentence that is worth reading slowly: I do not believe I can provide adequate care in this environment. Not a complaint about management, not a scheduling dispute, a clinical judgment written in the first person, submitted through official channels, and filed away. 12 of those nurses were transferred. 11 were not. They remained on the East Wing roster, continuing to work the ward they had formally documented as unsafe. This is the staffing collapse, and it did not announce itself as a crisis. It arrived as attrition. The experienced nurses who left were not replaced in kind. Personnel records from the same period show a pattern of lateral hires, staff with shorter training histories, provisional certifications, or transfers from adjacent departments without specialist backgrounds. The East Wing was not understaffed on paper. The headcount held. But institutional knowledge does not appear on a roster. What was leaving was invisible to the metrics. What was staying was the problem. The nurses who filed those requests were not being alarmist. They were being accurate. They were describing a ward where equipment failed, where patient loads exceeded safe thresholds, where the physical environment had already been documented in the building's own maintenance records as deteriorating. They had read the same building the structural reports had described. They simply did not have the authority to close it. What the transfer request data reveals is a timeline. The nursing staff began signaling distress in 1965. The administration's first formal acknowledgement of a systemic problem at the East Wing would not come until 1971. There is a 6-year gap between the warning and the response, and inside that gap, the ward continued to operate, now staffed by personnel who did not yet know what the nurses who had left already understood. The experienced staff were the institution's early warning system, and when they tried to leave, the institution held 11 of them in place and replaced the rest with people who had not yet learned what there was to fear. That detail matters, because what follows next is not the collapse of care through ignorance. It is the collapse of care through substitution, through the deliberate replacement of documented concern with available bodies. Here is the question the data forces us to ask. If deaths are coded correctly, patterns emerge. If they are not, the pattern is hidden inside the coding itself, buried not through erasure, but through precision, through the careful application of technically defensible categories that, taken individually, tell the truth, and taken together, tell nothing at all. That is what a forensic audit completed in 2019 found when it examined East Wing death certificates from a 3-year window, 1966 to 1968. 41 deaths reviewed. 34 of them carried the same structural feature. The listed cause of death attributed the fatal outcome to an underlying patient condition: pre-existing cardiac weakness, compromised immune response, advanced age compounding surgical recovery, each entry plausible on its own terms, each entry placing the explanatory weight on the patient's body rather than on the facility's environment. That is a choice. It may not have felt like one at the time, but it is a choice nonetheless. The audit team applied a different framework, the 1990 CDC criteria for nosocomial infection, meaning infections that originate within a healthcare setting, applied retrospectively to the original case records. Under those criteria, 19 of the 34 recoded deaths meet the threshold for healthcare-associated mortality. Not suspected. Not probable. Meeting the threshold. 19 deaths in 3 years, in a single wing of a single hospital. None were reported to the state as healthcare-associated deaths, not one. Now, there are 2 ways to read that number. The first is charitable. The CDC nosocomial criteria did not exist in 1966. You cannot hold a facility to a standard that had not yet been written. Physicians coded what they saw using the language available to them, and the language available to them allowed for ambiguity. That reading is accurate. It is also incomplete, because the question is not whether St. Maro's staff were coding deaths incorrectly by the rules of 1960. The question is what those coding rules made possible: a system in which post-operative infection deaths could be distributed across a dozen diagnostic categories: cardiac failure, respiratory collapse, systemic decline, is a system in which no single category ever accumulates enough weight to trigger a review. The pattern cannot become visible because the pattern has been subdivided out of existence before anyone thinks to look for it. That subdivision did not require conspiracy. It required only consistency. Consistent use of the available categories in the way available categories are typically used. The result was 34 death certificates that each individually passed review without question, and collectively, over 3 years, constituted something that looked very different from what any one of them said. The word for that in epidemiology is masking. Statistical responsibility distributed across diagnoses until no single diagnosis carries enough signal to produce an alarm. And the next question, the one this audit raises without fully answering, is whether the masking was incidental to the system or functional within it. Whether these deaths were simply coded the way all deaths were coded, or whether something about this wing, this period, this cluster of outcomes, made a particular kind of coding especially useful to those responsible for the wing's continued operation. That is where the record gets harder to read and harder to look away from. In 1967, the Virginia Department of Health sent an inspector to St. Maro. The visit was logged, the paperwork was completed, and the facility returned a compliance rating. 2 years later, in 1969, they came again. Same result. Compliant. Those two words, compliant, compliant, would appear in any administrative summary of this period as evidence that the system was working. That oversight was present, that someone had looked, but a compliance rating does not mean a facility is safe. It means the inspection found nothing. And whether the inspection finds nothing depends entirely on what the inspection was built to look for. That distinction matters here, considerably. In 2018, a FOIA request recovered the actual checklist used during the 1967 inspection. It is a bureaucratic document, careful in its own terms. It covers fire exits, pharmaceutical storage, surgical suite sterilization, exterior signage. It is organized, thorough, and detailed across the categories it was designed to address. What it does not contain is a line item for air exchange rates. There is no field for subfloor drainage conditions. There is no measure for staff-to-patient ratios in non-surgical wards. The wards where the majority of the deaths this audit examined were recorded. These were not oversights in the sense of errors. They were structural absences. The checklist was not designed to see those things, and so no inspector, however diligent, could have flagged them. The form did not allow it. This is the architecture of institutional blindness. It is not the same as fraud. It does not require malice. A badly scoped inspection instrument will return clean results in a dangerous facility every time, with complete procedural integrity, without a single falsified entry. And the maintenance logs, the internal records documenting drainage failures, irregular ventilation readings, and repeated mechanical complaints, those logs were already in existence when the 1967 inspector walked through St. Maro. The problems the checklist could not see were problems the facility's own paperwork had already named. The state saw what the state's instrument was shaped to see, nothing more, which raises the question that no compliance rating can answer. Not whether the inspectors were competent, not whether the visits were real, but whether the inspection methodology itself was designed in a way that made certain categories of harm invisible by definition, and whether anyone involved in designing that methodology understood, at the time, exactly what it would and would not surface. Because a tool that cannot detect a problem will always return the same result, regardless of conditions on the ground. And a facility that knows the contours of that tool has a very clear picture of where it can operate without producing a finding. When an institution writes down that it knows, the question stops being, what did they know? It becomes, What did they choose? In September 1969, St. Maro's chief of medical staff put that knowledge on paper. His memo to the hospital administrator described what he called an accumulating risk environment in the East Wing, one that, in his own words, exceeded the institution's capacity to manage safely under current resource allocation. He was not raising a speculative concern. He was documenting a condition. He was asking for a capital review immediately, before the situation moved further in the direction he could already see it moving. The administrator read it. We know this because the response is written by hand, on the same page, directly beneath the request. 4 words and a date. Noted. We'll revisit in Q1 1970. That phrase, "will revisit," implies continuity. It implies a future action that follows from a present acknowledgement. It implies that the thing noted will, in fact, be returned to. And so the natural place to look next is the Q1 1970 budget cycle. Because if the administrator meant what the phrase implies, that is where the East Wing should appear. It doesn't appear. There is no capital line for the East Wing in Q1 1970. No deferred allocation. No provisional funding. No record of a meeting to discuss the memo's findings. The acknowledgement was recorded, and then the acknowledgement was filed, and the condition it described continued without interruption. This is worth slowing down on, because the memo does not represent a failure of communication. The chief of medical staff communicated with precision. He identified the problem, he quantified the risk, and he named the remedy. The communication worked exactly as it was supposed to. What failed was not the transmission. What failed was the decision that came after it. And this is the point at which institutional responsibility becomes very difficult to argue around. Negligence, in its most forgiving construction, requires an absence of awareness. A person who does not know cannot be held to have chosen. But a person who writes the word "noted" and then does nothing has made a choice inside their awareness. The inaction is not a gap, it is a response. The memo survived. Memos like this often do not. They are misfiled, or lost in transitions between administrators, or simply absent from the record in ways that are never fully explained. This one remained. And what it establishes is not ambiguity. It establishes a timestamp, a moment at which the institution's knowledge of the East Wing's condition became formal, documented, and attributable, which means everything that happened after September 1969 happened in the presence of that knowledge. The question that follows from that is not a simple one, because the 1969 memo was not the first internal signal, and the administrator who responded to it did not operate in isolation. Decisions about resource allocation at St. Maro's moved through a structure, and understanding how that structure processed risk across time requires looking at what else was in circulation during the same years and what it did and did not reach. Everything established so far is on the record, not reconstructed, not inferred. The structural failures, the staffing decisions, the 1969 memo, those exist in documents that predate any investigation by decades. That matters because it means accountability does not depend on anyone's memory of what happened. It depends on who was required to act on what they already had. Here is what that record shows, taken together. The East Wing's death toll was not hidden, it was distributed. Spread across inspection logs, internal correspondence, maintenance requests, budget reviews, each piece held by a separate office, none of which was institutionally required to speak to the others. That fragmentation is not incidental. It is, in itself, a finding. Systems that cannot connect their own evidence cannot, by design, be held to account for what that evidence shows. That is where we stand at the midpoint. The building was failing. The staff knew. The administration knew. The inspection framework was structurally blind to what it most needed to see. What we have not yet established is how far up the chain that knowledge traveled, and what happened when someone, finally, in 2019, pulled all of it into one room. The audit that resulted from that effort does not simply confirm what was already suspected. It names things, and the question it forces is precise. Who held the whole picture and when? The 340% figure had a specific origin event. It did not emerge from a slow accumulation of bad outcomes spread evenly across years. It came from a window, roughly 20 months, and within that window, a chain of failures that were individually documentable and collectively fatal. Start with the structure. The East Wing's post-operative recovery rooms shared a ventilation system that had been flagged in 1967. Not condemned, not repaired. Flagged. The notation sat in maintenance records, and the ductwork continued to move air through the same corridors, where post-surgical patients were at their most immunologically compromised. In the winter of 1970, that air began carrying something specific. Klebsiella pneumoniae is an opportunistic bacterium. In a healthy person, it rarely establishes itself. In a patient recovering from abdominal surgery, with a compromised mucosal barrier and a body already marshaling resources toward wound repair, it finds exactly the conditions it needs. The East Wing's microbiological sampling, conducted internally, never submitted to state health authorities, traced the outbreak vector directly back to the compromised ductwork. The institution had the data. It had the causal link. It had both in writing. What it did not do was report either of them. Between January and September of 1971, 18 patients died with Klebsiella-positive cultures on record. 14 of those death certificates listed the primary diagnosis complication as the cause of death. The infection, the one with a documented environmental source, the one connected to infrastructure maintenance deferred for 3 years, did not appear as the mechanism of mortality. It appeared, if at all, as a secondary notation. The kind that does not trigger a review. The kind that does not surface in aggregate reporting to outside bodies. This is not a clerical ambiguity. A cause of death determination is a medical judgment made by a physician, recorded on a legal document. 14 times in roughly 9 months, that judgment landed on the primary diagnosis rather than the documented infectious complication. Whether that pattern reflects deliberate misattribution, institutional pressure, or the inertia of a documentation culture that had never been asked to look closely, the 2019 audit does not fully resolve. What it does establish is that the pattern was not random. And then there is October 1971. A board subcommittee convened to review East Wing mortality trends. The data was present. It had been compiled into a 1-page summary, which is itself a choice, the reduction of 18 deaths and a bacterial outbreak into a single page. And that summary was brought before the people whose institutional responsibility it was to act on it. The item was tabled. The recorded rationale, further data collection was needed. That phrase deserves a moment. By October 1971, the HVAC vector had been internally confirmed. The mortality cluster was documented. The microbiological link was in writing. What additional data was being requested is not specified in the board minutes, because the minutes do not specify it. The motion to table passed. The meeting moved forward. It is worth holding the geometry of that room for a moment. Someone prepared the summary. Someone presented it. The subcommittee members read it, or did not read it, and voted to wait. The 18 deaths did not become a crisis that afternoon. They became a pending item. What this beat establishes, then, is not simply that people died. It is that the causal chain was known at every link: the aging ductwork, the bacterial vector, the misattributed certificates, the summary document, the board vote. And that knowledge did not produce intervention. It produced paperwork that authorized delay. The question the 2019 audit presses from here is harder than causation. Causation, by this point, is almost settled. The harder question is accountability, and accountability requires knowing not just what was in the room, but who was in the room, what their roles were, and what obligations those roles carried. That is where the record becomes considerably more uncomfortable. Consider what isolation actually does to a system. It is easy to think of geography as a passive condition, background texture, a fact about distance and roads. But isolation is not passive. It is structural. It redistributes power. And in St. Maro's case, it redistributed power almost entirely away from the patient. The 6 counties that fed St. Maro's wing held roughly 34,000 people in 1970. That is not a city. That is a county fair spread across a landscape with almost no economic margin. Median household income placed the area in the bottom 12% of Virginia counties. These were not communities with options. They were communities that had learned, over generations, to work with what they had. And what they had was St. Maro. There was no second hospital within reach. The nearest comparable facility sat 94 minutes away by ambulance, over mountain routes that became genuinely dangerous in winter. Private transportation was not a reliable alternative. The 2019 audit found that 41 of the 47 identified excess deaths involved patients from households without a registered vehicle. That number deserves to sit in silence for a moment. 41 people for whom leaving was not a choice they could make unilaterally. This is what the care desert meant in practice. It did not mean inconvenience. It meant captivity, not enforced by walls, but by terrain, poverty, and the absence of alternatives. Now think about what captivity does to institutional behavior. Every functioning market, every accountability structure, every professional incentive toward correction depends on some version of exit. A hospital that serves patients who can go elsewhere must consider what happens if they do. Administrators may not use that language in staff meetings, but the logic is embedded in every system that actually works. Competition is not the only mechanism of accountability, but it is one of the most powerful. Remove it entirely, and something has to fill the gap. At St. Maro, nothing did. Families who suspected something was wrong had nowhere to transfer a parent, no leverage to apply, no credible threat to make. A complaint against the facility was a complaint into a void, filed with an oversight body that met quarterly and required written submission by mail. Even if a family pursued it, they would still need St. Maro next time. The mountain did not move for grievances. The hospital had no competitive pressure to correct. Regulators were distant and infrequent. The patient population was poor, rural, and politically marginal. No one with power was watching closely, and the people watching closely had no power. Geographic isolation did not cause the infections in that ward. It did not draft the falsified certificates or schedule the delayed repairs. But it removed every external force that might have interrupted the pattern. It sealed the system. The audit's phrase is precise. Isolation was not incidental to the death toll. It was load-bearing. Which means one further question follows. Someone built within this structure. Someone operated confidently inside it. Isolation of that kind does not persist by accident. It persists because someone, somewhere, finds it useful. Who benefits when there is no exit? If families were raising alarms, there should be a record of it. And there is. The question is not whether those records exist. The question is what happened to them once they arrived. The 2019 audit recovered 31 written complaints, filed by patients or their families between 1966 and 1973, that specifically referenced conditions in the East Wing. 31 documents. 7 years of accumulated concern, put to paper, signed, and submitted through official channels. 28 of those complaints were routed to the hospital administrator's office. Not one generated a documented response. Not one produced a corrective action order. There is no memo acknowledging receipt. No internal review. No record of any administrator reading them and deciding against a response. The complaints entered the office and disappeared into silence. That silence is itself a kind of evidence. The remaining 3 were forwarded to the State Health Department, which is, in theory, precisely where a serious complaint about patient safety conditions should go. State records show no follow-up investigation was opened on any of the 3. The complaints were received, they were filed. The trail ends there. One case stands apart from the others. In 1971, the family of a patient who died of a Klebsiella-positive infection submitted a written complaint that named, by name, the HVAC system as a concern. That complaint was not vague. It was not the expression of grief looking for an explanation. It was specific, technically grounded, and filed by a family that had done enough reading to connect ventilation to infection spread. A precise complaint about a precise mechanism. It was filed and closed on the same date it was received. The bureaucratic term for that is administrative closure. What it means in practice is that someone read that document, or chose not to read it, and marked it resolved before the ink was fully dry. No investigation was opened. No facilities review was requested. No one called the family back. What the audit established is not merely that the complaints existed. It established a pattern of institutional response. Families escalated. The institution absorbed the escalation without friction and without consequence. 31 times. That is not a series of oversights. That is a system behaving exactly as designed. Which raises the next question, the one that follows directly from the pattern. If the complaints were being received, and if someone in that administrator's office was making active or passive decisions about what to do with them, then there were people with direct knowledge of the problem. Not suspicion. Knowledge. Filed, documented, signed knowledge. What did those people do with what they knew? What those people did, it turns out, was close the wing, and then describe that closure as progress. In August 1973, the East Wing of St. Maro's was formally shuttered. The board resolution that authorized it cited 2 reasons: structural obsolescence and planned facility modernization. That is the complete stated rationale. Structural obsolescence. Planned modernization. Clean, administrative, forward-looking language. What the resolution does not mention is the 1969 memo from the Chief of Staff. It doesn't mention the complaint files. It does not reference a single mortality figure. There is no acknowledgement, however oblique, that anything in that wing had ever gone wrong for any patient at any point during the decade it operated. The same week the closure was authorized, St. Maro's issued a press release. The language there is even more revealing. The closure was described as, and this is a direct quotation, an exciting step forward for St. Maro's mission to serve the region. An exciting step forward. The termination of a clinical space carrying a decade of documented excess deaths was framed as institutional momentum, as ambition, as something the community should feel good about. This is not a subtle distinction. Closing a wing, because it is structurally outdated, is a facility's decision. Closing a wing, because patients were dying in it, at rates that could not be explained or defended, is a safety reckoning. One of those framings requires accountability. The other one doesn't. St. Maro's chose the framing that required nothing. The 2019 audit would later identify 47 excess deaths attributable to the East Wing across its full operational period, 1963 through the August 1973 closure. Those deaths did not appear in the resolution. They did not appear in the press release. They did not, as far as the available record shows, appear in any internal communication tied to the closure decision at all. So the wing closed, and the closure erased, or at least buried, the reason it should have closed years earlier. That is the mechanism worth studying here. Not just that the institution failed to act when it had knowledge, but that when it finally did act, it constructed a public record that made the prior inaction invisible. The closure became the story, which meant everything before the closure had no story at all. That raises the question that follows directly from this. If the framing was this deliberate in 1973, then who specifically was responsible for constructing it? And what did they know when they wrote it? Here is what the 2019 audit found. Not speculation, not reconstruction. The documented figure, the causal chain, and the answer to every question that has been opened since the beginning. 20 That is the number the University of Virginia epidemiologists arrived at after reviewing facility records, state inspection logs, staffing documentation, and patient outcome data spanning 1963 to 1973. 47 deaths meeting formal criteria for facility-attributable excess mortality. The attribution rested on 3 documented conditions operating simultaneously. Confirmed nosocomial infection vectors traceable to physical plant failures, staffing ratios that fell below clinical safety thresholds on a chronic and recorded basis, and structural conditions the audit described as inconsistent with safe patient care. These were not contested findings. They came from the institution's own records. The audit then did something more precise than count the dead. It mapped the decision architecture around those deaths. 9 discrete points in time at which the information available to responsible parties was, by the audit's determination, sufficient to justify closure or major intervention. 9 moments. At none of them did closure or major intervention occur. That is not a pattern of missed signals. It is a pattern of adequate signals, adequately received, and consistently not acted upon. The distinction matters. And then there is the finding about the inspections themselves. The state inspection methodology in use through 1973 was, in the audit's language, structurally incapable of detecting the conditions present in the East Wing. The criteria prioritized administrative compliance. They were not designed to assess clinical environment. The audit did not call this an oversight. It called it a design outcome. The inspections were passing the wing because they were built to pass it. That closes the question of who knew. The answer is that the inspection system was architected so that formal knowledge, the kind that creates legal and administrative obligation, could not accumulate. The death machine, as this analysis has argued from the outset, was not an accident of neglect. It was a predictable output of layered institutional decisions about what to measure, about what to record, about what to act on, and about what to design so that action would never formally be required. 47 people, 9 decision points, 0 interventions, 1 inspection regime built not to see. The audit names those 9 decision points. It names the responsible offices at each one. That record now exists. What happened to it after 2019 is a different kind of question, and it turns out to be a question with its own answer. What happened between 1958 and 2019 is not a timeline of mishaps. It is a single mechanism operating as designed. That framing matters. When we treat institutional failures as sequences, this administrator, then that policy, then that underfunded year, we preserve the illusion that different individuals would have produced different outcomes. St. Maro's East Wing dismantles that illusion with precision. The infrastructure that opened the wing in 1958 was already shaped by rural funding formulas that assumed density of oversight, which did not exist in that geography. The inspection architecture layered on top of that infrastructure was calibrated to detect acute, visible failures, not slow, distributed ones. The administrative filing practices that accumulated across 4 decades were not cover-ups. They were a rational response to a system that rewarded documentation completion over documentation coherence. And the geographic monopoly that insulated St. Maro's from competitive or community pressure meant that the one corrective force external to the institution was never activated. Remove any one of those 4 conditions, and the outcome changes. Keep all 4 in place, and 47 deaths become, in the language of systems analysis, an expected variance. That is the architecture the 2019 audit finally made visible. Not a scandal, a structure. And this is where the case stops being historical. Underfunded rural infrastructure still operates on those same density assumptions. Inspection regimes in analogous facilities still measure what they were built to measure, no more. Geographic monopoly in healthcare delivery has not contracted. In many regions, it has expanded. And filing practices that distribute rather than concentrate documented risk remain standard in institutions that have never been audited at all. St. Maro's East Wing did not fail because people were careless. It failed because the system surrounding it had no working mechanism for failure to become legible before it became catastrophic. The question is not whether that architecture existed. The question, the one the 2019 audit leaves open, is how many buildings are still running on the same blueprint. The 2019 audit, the 1967 inspection checklist, and the 1969 Chief of Staff memo are all in the public record. Links are in the description below. Read them. The inspection design finding is the one worth sitting with. The problem was not what inspectors found, but what the form made it structurally impossible to find. That question has a longer history. The next video follows that same inspection template across 4 other Virginia counties through 1980. The blueprint did not stay in one building.